Hello, everybody. This is York Pei. I'm going to talk to you about what the polycystic kidney disease clinical care looks like in 2021. So the objective of this talk is to review for you the clinical features and pathobiology of ADPKD, highlight the recent progress in genetic, molecular, and cellular research, and illustrate how this knowledge is being translated to improve prognostic testing and treatment. So ADPKD is the most common hereditary kidney disease worldwide, with a prevalence affecting 1 in 1,000 births. Recent studies have shown that about 3/4 and 1/4 of the cases are due to mutation of PKD1 and PKD2 respectively. The distinction between mutations in these two genes is important because PKD2 is a much milder phenotype compared to PKD1, with a delayed onset of end-stage kidney disease by about 20 years compared to the PKD1. Overall, ADPKD account for 5 to 8% of end-stage kidney disease. And given that tolvaptan is now approved for treatment of patients at high risk for ADPKD, there is an imperative to identify these individuals, and that will form the focus for the bulk of my presentation. So, risk assessment to identify patients who are at high risk for progression to end-stage kidney disease is likely going to be an important integral component of the work of a nephrologist when he or she see the patient with ADPKD. Traditionally, we can look at clinical predictors of disease severity, such as early onset hypertension, gross hematuria, or early decrease in GFR. But for risk assessment, we rely on two other modalities. One is the use of imaging to assess the cystic kidney disease burden, and we use total kidney volume as a surrogate marker when combined with age to allow one to assess the severity of disease. Since this is a genetic disease, there are specific mutation class that is generally associated with severe disease, such as in the case of PKD1 truncating mutations. So I'd like to start off with a presentation on the role of mutation for prognostication. This is a schema showing PKD1 and PKD2, the genetic or genomic structure. And as you can see, PKD1 is a very large gene. It's a complicated gene because 3/4 of it is duplicated and is present in pseudogenes that are very similar in sequence to PKD1 nearby. Because of this complication, mutation analysis has to be very carefully done so that the genetic sequence that is unique for PKD1 and not the pseudogene is being sequenced to identify the mutation. In addition to this complexity, this is also a large gene, therefore require a lot of effort for screening. PKD2, on the other hand, is a smaller single copy gene, which is amenable to conventional Sanger sequence-based analysis. Before I show you the information on how the gene mutation correlate with the phenotype, I'd like to discuss with you that when we think about the effect of mutation, we can, in general, think about two different classes of the genetic effect from the nucleotide changes. The first are the typical classic protein truncating mutations These are the ones such as one associated with stop codon, splice junction mutation, or frameshift insertion or deletion. Essentially, these mutations result in a truncated protein product, and in the case of PKD1, it would be missing the 3' or intracellular tail of the protein. The second class of mutation are non-truncating mutation, which could take the form of a single amino acid change affecting a highly conserved residue during evolution, or in-frame insertion deletion of several amino acids, but the reading frame remained maintained so that the terminal tail of the protein remained intact. As an illustration on the genotype-phenotype correlation in ADPKD, I want to show you a study we did in Toronto called the Toronto Genetic Epidemiology of PKD, in which we screened mutation and characterized the clinical features of 220 families. So from this study, we learned that about 15% of the cases, we could not find a mutation despite fairly comprehensive screening. On the other hand, PKD1 protein truncating mutation, which is shown in the navy blue, account for about 1/3 of the cases. PKD2 account for about 1/4, and the non-truncating or PKD1 in-frame indels account for another 25%. From this study, we have the initial probands, who are the affected individual for each family, who are being assessed. And we also recruited additional affected members of their family. So in total, 780 patients from 220 families were studied. From the clinical information and the genetic information, we can see that these patients can have varying effect from the genotype. On the left-hand panel, you can see the renal survival as defined by the need of end-stage kidney disease care. And the median age for PKD1 protein truncating mutation is about 55 years. So this is the most severe genotype. By contrast, you can look at the orange curve, which is PKD2 patients. The median survival is at age 80. So very big difference in the age of onset of end-stage kidney disease. And in between, you can have the purple, which is the small group of in-frame insertion deletion of PKD1 gene, which is closer to the protein truncating PKD1 mutation in terms of the disease severity. And then there is a group shown in the light green curve, which is the missense non-truncating mutation. They are associated with generally mild disease, more similar to PKD2. What is interesting is the line shown in the gray are the ones with no mutation detected. These are individuals that also does very well in terms of the renal survival, and I will go back to tell you more about what could be the cause of this group of individuals. From the renal survival, we can also further extend to patient survival on the right panel, and you can see the navy blue line is associated with a decreased survival in the PKD1 protein truncating group. And this is because if you started dialysis earlier than the other groups, this requirement of dialysis is also associated with decreased survival. One of the problems in assessing genetic changes is that there is the presence of intra-familial variability. as shown in this slide. So in this slide, these are families we have studied in Toronto. On the y-axis, you have the age of onset of end-stage kidney disease, and the family members are shown on the family study family number are shown on the x-axis, and each vertical line represents a family, each dot one of the affected individual. So you can see that within the same family, you can have someone who would not require dialysis until past age 80 to someone who started dialysis in the early 40s. So this kind of variability suggests that there is a modifier effect due to other genetic as well as environmental factors. And in fact, we have seen that within family, there are discordant affected relative pairs in about 12% of the family that we have studied. And this render risk prediction at the individual patient challenging. So what could be the cause of the intrafamilial variability? We now know that some of the family that display this kind of variability, in fact, harbor more common the mutation that is shown in one of the parents as a germline mutation, but hidden in it are further complexity. So on the left panel, you have a family in which apparently you have a man who had end-stage kidney disease at age 73. He had 5 children, and of note, all 5 were affected, which is highly unusual, given that this is a dominant effect, the dominant disease with 50% transmission expected. So it turns out that this family, the mother, who was not known to have ADPKD, in fact carry a missense PKD1 mutation, and she actually had very mild phenotype that was not recognized. And individual who carry the light blue bar, and these are the ones that had this single amino acid deletion of valent 4130. 3 of the children carry them. And then, in fact, the other 3 other children carry the maternal mutation, which is a S4054F substitution mutation. And you can see that of the 5 children, 1 actually carry both mutation, and her disease is much more severe than her other siblings. She actually developed end-stage kidney disease at age 24. Another unusual manifestation of severe disease that are discordant with family is also shown on the right panel. The patient is a lady who had end-stage kidney disease at age 44, and her father at age 82 was free of end-stage kidney disease but had a few cysts in the kidney. And it turns out the father carried a missense PKD1 mutation, valent 2538 methionine substitution. But the individual that is severely affected also acquire an additional de novo protein truncating mutation in the maternal allele. And as a result of that, her disease is much more severe. Additional example of the complexity of ADPKD is shown in this slide, which is an example of genic interaction. On the left panel, you have a large family, which we study from Newfoundland, and all the blackened symbol denote individuals who are affected. And you have some who are carrying a blue haplotype, which is a PKD1 haplotype, and those who carry the red haplotype had PKD2 mutation. It turns out the PKD1 mutation is a missense mutation, so it's associated with very mild disease and very similar to PKD2. And if you plot the creatinine clearance of this individual on the y-axis, you can see in the lower panel figure, and against the age on x-axis of this individual, those carrying the blue dot and the red dot really very similar in terms of their kidney function. So both groups of individuals appear to have very mild disease. But you also see two individuals shown in green, and they actually carry both mutation, and they are shown in the figure there with the blue and the red haplotype. These individuals were more severely affected, demonstrating the additive effect of having two mutations, and also illustrating that some of the intra-familial variability is underpinned by this kind of genetic complexity. This is another family which is unusual, and this is two PKD patients marrying each other. On the left-hand side, the husband is someone who had known to carry a PKD1 protein truncating mutation. The wife is known to actually carry a PKD2 protein truncating mutation. And the family member and pedigree are shown in the panel A. They have a child which was born with echogenicity of the kidney and kidney cysts. And it turns out this child actually had polycystic kidney disease and manifesting intrauterally and picked up by screening ultrasound. And he carried both the PKD1 and PKD2 mutation. And he's expected to have more severe disease compared to either of the parents. So one other aspect of genetics that I like to talk to you about is the concept of somatic mosaicism. So up to now, what I've been telling you is that ADPKD is transmitted through the germline. That is to say that one of the parents carrying the genetic defect pass on the disease at the time of conception. That is when the sperm fertilized the egg. So either the sperm or the egg carry the mutation, and subsequent to them, the individual being that came forth will have every cell carrying the affected familial PKD mutation. Somatic mosaicism is a very interesting phenomenon in which the genetic disease is not acquired at the time of conception, but rather during early embryogenesis at maybe 8, 16, or 32 cell stage, in which one of the polypotent stem cells acquire PKD mutations. Because these are all essentially stem cells that give rise to different tissues and organs, the disease of a somatic individual is very much diluted. And presented typically focally and in a very mild manner. So mosaic individual had been documented in many medical diseases and typically presented with much milder version of the disease and often with atypical and focal features. Does it happen in PKD? So this is an illustration of the family that we have studied. So shown here is that the mother, who at age 55 had asymmetric polycystic kidney disease. Her left kidney was largely cystic, but the right kidney is normal size with only relatively fewer cysts. And at age 55, her height adjusted total kidney volume is the same or actually slightly less than her affected daughter, who was age 19 but with much more severe disease. So what is the genetic underpinning of this family? You can see in this Sanger sequence tracing, the normal control is shown in the upper panel, showing the normal sequence of the gene of region of interest that show the familial mutation of TOR135. The daughter, denoted by D at the bottom sequence, show that you have a typical frame shift mutation. You see the double peaks after fairly normal looking tracing. This is due to a deletion of one base pair result in a frame shift. When you look at the maternal tracing, these kind of changes are also shown, but at much lower level, and it looks more like a dirty PCR tracing. But in fact, this is actually a specific mutation. And the reason why it didn't look with the normal 1-to-1 ratio of the two allele is that the disease is attenuated because of mosaicism. And in fact, when you do the quantitative analysis of the mutant allele compared to the wild type allele on the right side panel, the mutant allele in the mother is about 1/10 of amplitude compared to the normal wild type allele. So mosaic individuals typically do not have a family history because the disease is not transmitted from their parents. It's acquired during early embryo development. And they typically have unusual feature of PKD, either in the form of asymmetric polycystic kidney or other type of unusual presentation, which I will touch upon a little bit later. One of the problems is detection of this individual because it's illustrated in the Sanger sequence tracing of the mother. The disease allele, the amplitude is much attenuated compared to the wild type normal allele. And so often it can be missed when you do Sanger sequencing. However, with recent advance in next generation sequencing, we are now applying next generation sequencing to sequence the PKD1, PKD2, as well as a panel of cystic disease gene in very high depth. And with that, we would be able to pick up mosaic mutation that may be down to 2 to 5% of the amplitude of the allele compared to the control. So now I'd like to turn to kidney imaging-based prognostication. One thing we have learned about polycystic kidney disease is that creatinine-based GFR estimate generally change late in the course of disease, and therefore it's not a sensitive marker for picking up disease progression. By contrast, the kidney volume, as measured by MRI or total kidney volume, increase quasi-exponentially, and it's a robust surrogate biomarker of cystic disease burden. Using total kidney volume adjusted for height and age can give an assessment of the severity of the disease. So this is the Mayo Clinic imaging classification, and shown on the upper panel, you can see a group of individuals that had PKD and being studied, and their height adjusted total kidney volume is shown in the y-axis in a log scale, and then the age of the study subject on the x-axis in a linear scale. There's a lot of overlap, but if you group patients in the under the light green bar, like those individual as class 1A and 1B, you can generally separate the individual who have mild disease and on the eGFR panel that have a slower slope of decline of eGFR. By contrast, those in the orange or gold line at the upper part of the graph, they have a rapid growth of a total kidney volume, and on the bottom graph, they're associated with much more rapid decline in their kidney function. And you can see the cystic burden on the right panel associated with the different class. So class 1A, 1B typically have mild disease, and as shown in the MRI image, 1D, 1E typically have very severe disease, and 1C kind of intermediate disease. So the next topic I'd like to cover is to tell you a bit about the molecular pathway for cyst growth and how this knowledge is being translated to developing novel treatment. So we know that polycystin 1, which is a protein encoded by PKD1, the intracellular tail or the 3' end of the gene actually has an important function. And this intracellular tail actually complex with multiple protein, including Hamilton, tuberin, which are the TSC1, TSC2 gene product of another cystic disease. And this protein actually together keeps another protein called mTOR, or mammalian target of rapamycin, in check. Mammalian target of rapamycin is a key energy sensor of cellular metabolism. And so when it is inactive, the cell is in a resting state, but when it's auto-activated, then the cell can actually result in a proliferative state. When mutation affect PKD1 and the 3' end of the gene and truncating the polycystin protein, this complex of Hamilton, tuberin, and mTOR is unleashed, and then the mTOR become auto-activated and leading to an increased growth effect of. This is on the right side, the graph show that the effect of mTOR activation resulting from conditional inactivation of PKD1, you can have a very cystic kidney disease shown in the middle panel. And if you treat the mouse in this model, or the mice in this model with rapamycin, which block the mTOR complex, the cystic disease is greatly attenuated. So this is the experimental evidence showing the importance of mTOR 1 activation and the potential use of mTOR inhibitor as a treatment. mTOR inhibitor is not going to be very useful for human use because of side effect. By contrast, experimental studies have also highlighted the importance of increased cyclic AMP in the cellular epithelium, whether in human cystic disease or in animal models. And the increased cyclic AMP as a second messenger in the cell promotes its growth. And Dr. Vincente Torres from the Mayo Clinic reasoned that one can use pharmacological means to reduce cyclic AMP in the cystic tissue, and in the case of polycystic kidney, potentially to attenuate the cystic disease. And so this hypothesis was tested using a vasopressin V2 receptor antagonist to block this signaling pathway to lower cyclic AMP. And you can see in the experimental model, which was used to test it, it's a PKD2 aggressive mouse model called PKD2 null WS25. the untreated mutant mice, the kidney were significantly cystic. The treated mice, the disease was very significantly attenuated. And these results was very encouraging, and it was also tested in additional models showing very consistent attenuation of disease severity. So based on this preclinical study, there are two large trials involving patients. The first one is the TEMPO-3-4 study, a 3-year study, placebo-controlled trial involving more than 1,400 patients. And the tolvaptan twice daily versus placebo was given in a 2-to-1 ratio. The baseline total kidney volume of the study patient was 1.7 liter, so they already have moderate disease. And on the other hand, most of these patients have fairly normal eGFR. And the outcome of the study was the annualized rate of change in total kidney volume. So one of the challenge of this study, because of use of tolvaptan as a V2 receptor antagonist, is that it will cause a pharmacological form of diabetes insipidus. The patient who are on the active drug will be peeing buckets, and potentially can unblind the study. So part of the design is that they don't measure 24-hour urine output, and in addition, they ask everybody to drink lots of water. So even in the control group, the control individual getting placebo also drank a lot of water and also pee a lot. So so this allow the potential avoid the potential bias of unblinding one group versus the other, but at the same time may minimize the actual treatment results because the placebo group also had high water intake. So this study has actually a very important kind of finding, and you can see that the tolvaptan treatment in the blue line is associated with a slower expansion of total kidney compared with the placebo group shown in the red. On the right-hand panel, you can see that the rate of decline in eGFR, the tolvaptan treated group in blue have a less steep decline in the slope of creatinine clearance or eGFR over time compared to the placebo. A second study following the TEMPO-3-4 is the REPRISE study. It studied a different group of patients who had more advanced disease. And so the outcome of this study is the rate of decline of eGFR rather than change in total kidney volume over time. You can see on the left-handed table that the two groups of patients are somewhat different. The TEMPO-3-4 include a lot of patients in with CKD stage 1 and 2, whereas the REPRISE study involved a lot of patients in the CKD 3B and 4. And the finding of this study is that tolvaptan was associated with less decline in the eGFR slope compared to the placebo-treated group. So based on these two studies, tolvaptan has shown efficacy in slowing total kidney volume expansion, slowing the rate of decline in kidney function, and also reducing symptoms such as kidney pain. On the other hand, it is an expensive drug with potential for serious toxicity, specifically liver toxicity, and electrolyte imbalance, and even AKI. So it is approved for clinical use in Canada, but it should be reserved for high-risk patients, whether those with PKD1 truncating mutation or large total kidney for age. Those are potential criteria for selecting the individual for treatment. I'd like to turn to talk to you a little bit about an experimental procedure, which we are very excited because it may actually have another way to deal with the cystic disease called foam sclerotherapy. So one of the issues about polycystic kidney disease is when you have large cysts in the kidney, each cyst is derived from one single nephron, but the effect of the cystic expansion is much more than affecting that individual nephron from which the cysts arise. This is the right-hand panel show you MRI of the different cysts within the kidney. You could see the deeper cysts, particularly very large cysts, can have a tremendous field effect. That is to say, one cyst that is enlarged can press on many of the tubules because of the orientation from cortex to medulla, so affecting, causing micro-obstruction of many nephrons. So if that is the case and you have a patient that is like the one shown here, the one on the left-hand side, actually the axial view showing in her case the right kidney had a centrally located, fairly large size kidney, about the size of an orange, about 5 centimeters. And then the coronal view is shown in the right panel. So if you take out that right large kidney cyst, would it have any benefit in protecting the kidney from the loss of function over time, and also perhaps improving the blood flow to the kidney? So this is a procedure we have actually tried, and it's called foam sclerotherapy. It's a procedure in which the interventional radiologist would image the kidney. The patient is facing down right now, and Dr. Slomovich is doing the procedure, and he can see the kidney using ultrasound. And you can see this patient has several very large cysts. He would put in a catheter into the targeted cyst and inject some, drain the cyst and inject some dye to confirm that there's no leakage, and then prepare a foam formed with a sclerosant called STS. STS is a detergent surfactant-like chemical which can be used to destroy the cystic lining. When combined with air bubble, it forms like a shaving cream-like kind of a viscous liquid that can be used to coat the inner surface lining. And this is one cyst aspirated about 90 ml, and then 120 ml fluid. So targeting 2 cysts can actually significantly decrease the volume of the kidney. And so after the procedure, the patient is injected, and then with the sclerosant, then he or she would go to the recovery room, and they would turn the body 1/4 turn every 15 minutes. And by the end of 1 hour, the whole cyst would be rotated, and the fluid that is sitting in a dependent area would have coated the entire cyst. The patient then returned to the radiologic suite, and then have the sclerosant foam-like material removed, and then the catheter removed and discharged. If the cyst is very large, and we have some giant cysts, sometimes like greater than 10 centimeters, we would actually leave the drain in, have the patient come back for a second injection 1 week later. So this is a feasibility study showing a group of patients, 66 patients who underwent this procedure. We are primarily interested to demonstrate that it is safe, and so it's not an efficacy study, but more safety study. So you can see that in the targeted kidney volume pre and post shown on the left-hand panel, and the targeted kidney volume non-targeted kidney volume shown on the right-hand side pre and post. So on the left-hand panel, you can see a very significant decrease in the total kidney volume after the treatment at least 3 months after, showing that the effect is permanent. The non-targeted kidney on the right panel showed a slight increase over time. And the decrease in the volume in the target kidney is almost 22%, whereas the increased volume during the same time period on the non-target kidney is about 4.3%. So this procedure was well tolerated in the majority of patients. In about 15% of them, they may experience self-limiting pain greater than 24 hours of moderate to severe intensity and may need to have an analgesic for a few days. About 2% of them would be complicated by cyst infection requiring antibiotic treatment. So by and large, a very safe procedure. The last topic I'd like to discuss with you is drug repurposing for treatment. There are many preclinical studies in ADPKD showing that a number of drugs can potentially have benefit to slow cystic kidney disease. We already have talked about mTOR inhibitor, and we also talk about cyclic AMP antagonism type of drug treatment. One class of drug that is of interest is a metformin-based drug and metformin-like compound, because this drug induces AMPK, another protein, which is a negative inhibitor of mTOR. And I already mentioned that mTOR is auto-activated in ADPKD. So in the case of ADPKD, AMPK level is suppressed. If one can activate AMPK to suppress mTOR, this may be a way to bypass the mTOR toxicity using mTOR inhibitor. So one aspect that had garnered a lot of interest is that AMPK is also an important cellular sensor of energy metabolism. When its function is deranged, it results in metabolic reprogramming of the cell. So I'd like to show you some information about that PKD tissues are very much like the tumor tissues. They express or display a so-called Warburg effect, which is also analogous to aerobic glycolysis. And what is Warburg effect? So in normal differentiated tissue, in the presence of oxygen, glucose is fully utilized in the mitochondria and oxidized to generate 1 mole of glucose, generate 36 mole of ATP. In the absence of oxygen during hypoxic hypoxic condition, differentiated tissue will channel their glucose to pyruvate to form lactate instead of going into the mitochondria. And this is an inefficient way of generating ATP. What is interesting is in tumor, in proliferative tissue, and I'll show you including ADPKD, even in the presence of oxygen, glucose is not preferentially being channeled to the mitochondria to extract ATP, but rather is largely diverted to form lactate. So this is the Warburg effect shown in ADPKD. And this is a PKD1 knockout mouse study and showing that the cells culture with PKD1 null in the open symbol here in the left upper panel compared to the solid bars, the wild type control, you can see that there's an increased glucose utilization and increased lactate production. So, and this is associated with decreased AMPK signaling and increased mTOR signaling. So, realizing that AMPK and mTOR play an important role in cystic disease growth, and that the cystic cell like to use glucose to generate lactate, and presumably lactate is a 3-carbon moiety that can be used as building blocks of macromolecules. So you don't want to break it glucose into 6 individual carbon to get ATP, but you really want to have 3-carbon moiety that can be quickly channeled to build macromolecule. So if you block this kind of energy utilization or metabolic pathway, would it have an effect on cyst growth? And so on the right panel is a study using a glucose inert analog, 2-deoxyglucose, which cannot be metabolized. So this analog competitively kind of inhibited the glucose glycolytic pathway. And as a result, you can see the cystic disease is attenuated when the 2-DG is applied to this model compared to the control, which received normal saline. And you can see the cystic disease being less severe in panel C compared to the saline control. So this experimental study in the PKD1 knockout mouse model showed that metabolic reprogramming is an important feature of ADPKD that can be potentially exploited for therapy. So this is the human PKD1 cyst, and compared to individual minimally cystic tissue from the same patient, and we perform a system biology study. And what we find is that the right and the red and green color denote activated or downregulated genes or pathway. So, so you can see that the Wahlberg effect is light up in red, and certain growth factor that stimulate proliferation is in red. And then this, in effect, result in a number of metabolic reprogramming genes that are also shown in red. But the effect of glucose utilization, which normally goes through the mitochondria, is very different compared to a normal situation. It's mostly green. That is to say that glucose is not being metabolized in the mitochondria. And this is not just glucose. You can also see fatty acid and branched-chain amino acid. Normally, they would be degraded, and then the intermediates would also be oxidized in the mitochondria to extract ATP. And so these were actually suppressed. What is interesting is AMPK is downregulated here, and AMPK, as I mentioned, is a negative regulator of mTOR. mTOR autoactivation stimulates HIP-1 alpha, a hypoxia inhibitory factor 1 alpha, which is the gene that stimulates a lot of targets that are responsible for the metabolic reprogramming. So with this understanding, AMPK is an important therapeutic target. We know that its activity is decreased in polycystic kidney disease, and if we could activate it, then we could potentially use it as a form of therapy. And we already know that metformin, which is a type 2 diabetic drug, can can indirectly activate AMPK by inhibited the electron transport chain in the mitochondria. But they're also direct activator as well. And there's a compound called A769662, an experimental compound, as well as an old drug, salicylate, okay, which is related to aspirin, acetylsalicylate. So I think these are important ways to activate AMPK. And then there's another body of literature showing caloric restriction and can also activate AMPK and restore the metabolic reprogramming defect to attenuate cystic disease. So we actually did a study looking at the role of metformin, salicylate, canagliflozin individually as in combination on AMPK activation and cystic disease attenuation. Canagliflozin is a SGLT2 inhibitor, and it's an anti-diabetic drug. It also has an off-target effect to activate AMPK. That was why it's selected for this study. We use the dosage in the mouse model that mimic and give rise to blood level that would simulate the human clinical setting in this study. And we use a tamoxifen inducible PKD1 knockout mouse model with moderate disease severity, and this mouse would develop moderate disease by about day 75 after birth, and by 4 months significant disease. And so we use the endpoint of urea creatinine greater than 20 mole as a readout for kidney failure. And we monitor mice from day 75 to 4 months on a weekly basis. And then all the animals that reach the endpoint of BUN greater than 20 would be sacrificed. When the untreated control mutant mice reach 50% of the survival plot, all the groups would be sacrificed at the same time. So this is a survival plot using the criteria that I just mentioned, and then basically looking to see if any of these drug or combination of drug can improve the kidney survival compared to the mutant control shown in the red, shown in the black line. In fact, actually, only the salicylate and salicylate metformin group had a benefit, but metformin group did not. So the salicylate metformin group, the effect is largely due to salicylate and it's not due to the metformin. We also look at potential synergism of salicylate with tolvaptan and shown that the two drugs actually work synergistically. So this is showing that the different mutant treatment group, the untreated mutant control, salicylate treated, the kidney is smaller, less cystic. Metformin in our study did not have any effect, and metformin salicylate is a little bit smaller. And the cystic index, kidney body weight ratio, they are consistent with a salicylate treatment effect. And so what we find is that by transcriptional analysis of the PKD1 knockout kidney of the different group, salicylate effect is mediated through two major mechanisms. One is that it normalizes the metabolic reprogramming defect. The second effect, which is quite interesting, is it actually downregulate innate immunity to reduce inflammation in the kidney. So this is just shown in the green. So I think I just want to say that the salicylate work is very interesting, and we actually have now preclinical data to justify the human kind of drug repurposing clinical trial, which we will actually be doing a pilot study through the funding of the CKD SPOR CRHR grant. And this is a national study that we direct and support 10 centers to do risk assessment to identify high-risk patients with ADPKD and to do a pilot clinical trial, mostly a safety trial, and in this case, a salsalate. And in the future, we hope that we can advance this kind of research using repurposed drug, which is an old drug that are repurposed for new indication, and they have excellent safety profile. And hopefully this can provide additional treatment for patients with ADPKD. So in conclusion, I think that the pathobiology of kidney disease progression in ADPKD is highly complex, but targeting cyst growth likely has the most impact. Drug safety and tolerability is essential because for the patients, once they are on a disease-modifying drug, one can expect that the drug treatment duration will be measured in decades. So safety would be really important. And in the future, I think we will likely have more than one drug aside from tolvaptan. And hopefully we can use multiple drugs that may be synergistic to enhance the therapeutic effect, at the same time minimize the side effects. And whether the medical treatment can be used in concert with additional interventions such as the foam sclerotherapy, I think this would be kind of a research question that we need to study. So these are the final slide, the acknowledgement and all the patient and research granting agency that have supported our work. And thank you very much for your attention.
Well, thank you very much, Dr. Pei, for that fantastic and informative presentation. I know we have a little less time than we liked, but we will plan to go through the questions collectively once Dr. Pei joins us here, and there he is. Dr. Pei, it's good to see you again. Thank you for joining us from beautiful Vancouver. Nice and early there for you. You can hear me okay?
Yes, I can. You hear me okay?
Yes, I can. So let's run through some questions that have popped up. The very first one, how bad is caffeine for PKD? Does it significantly accelerate cyst growth or kidney impairment? How strong is the evidence on this? Does it matter what the source of caffeine is, coffee versus tea? Could you speak to that?
I think it's difficult to say. I think the evidence is based on like a test tube study of cells, not whole animal study. And so there is evidence that if you use a high dose of caffeine, it may have bad effect. So I would just say from a common sense approach, if you're a very heavy coffee drinker, it probably would be prudent to cut back. And but probably 1 cup or 2 cups of coffee, not a strong coffee, is probably okay.
Okay, thank you very much. Food for thought for me to watch my caffeine intake as well. How would someone know if they have PKD1 or PKD?
The only way to know really is by genetic testing, which I think is possible nowadays. It really depends on the purpose of why we want to do that. Just to diagnose ADPKD, typically, if you have a strong family history, you can use imaging kind of approach by ultrasound. You don't need to know the genetics. I think that the genetics may serve a purpose of prognostication to pick out patients that may have a high risk for progression, for intervention. And so I think in that case, my preference still would be to measure the height adjusted kidney volume, adjust for the age. because the genetics at the moment is a bit more complex to interpret, and not all even PKD1 truncating mutation are associated with severe disease.
Okay, thank you. We have a question here from Kevin Fowler. I went into renal failure at 43, and my sister is projected to have her native kidneys until her early 70s. Can you explain the intra-family variability?
Yeah, so as I try to illustrate, it is complex and not well understood. In some family, and this is generally uncommon, there may be more than one mutation segregating. So there may be a main mutation, like from one of the parents, and the second parent may have a, let's say, a mild PKD1 missense mutation, which are relatively common in the general population. That are segregating in some of the affected children, but not all. So in individuals who unfortunately get both mutations, they may have more severe disease than would be expected. And so you may see variability in this way. Then, of course, also environmental factors. So some individual, for other reasons, such as their way of lifestyle, may have other risk factors such as diabetes or overweight or uncontrolled blood pressure, which can modify the disease severity within family as well.
Okay, understood. Thank you. Would you be able to comment on the risk of transmission of those with mosaic mutations to their offspring?
Yeah, so I think that is not well known, but if you make the assumption that the mosaic individual, the mutation affect, let's say, 5 to 10% of their body cells, so there's a couple possibilities. If those cells do not give rise to the germline, i.e. The cells that make up the sperms or the eggs in an individual, the disease will not be transmitted. But if they happen to transmit to the germline, then the risk would be less than the 50% that is the typical form of ADPKD, more reflecting on average the 5 to 10%. So still much less likelihood of transmitting to the next generation than the typical familial form of ADPKD.
Okay, thank you. Is metformin moving into phase 3 trial?
I don't know. The feasibility has just been published in Kidney International, but it's a safety trial, basically showing that it's relatively well tolerated. We are a bit concerned that the dosage used in human, that is up to 3 grams per day, may not be able to provide a high enough blood level or tissue level that is required to effect the anti-PKD proliferative effect. And also because it is a non-patent drug, moving to a phase 3 clinical trial will be very challenging because it is hugely expensive, and how to fund that would be a very difficult challenge. There are other drugs that may be picked up by pharmaceutical company. As I mentioned, AMPK activator, there are some that are made and with patent and likely could be picked up by pharmaceutical company for later phase clinical trial. And so I think regardless, I think AMPK therapeutic, I hope that there will be a future that we will see being applied to ADPKD.
Great, thank you. What are your thoughts about the use of Triptorgeum wilfordi, God's thunder vines, in ADPKD?
This is a very old study that was published at one time, and I believe there was actually a study done in China, and for some reason, I think my understanding, it was abandoned that because of lack of efficacy. So I would say that, like, there are many studies that are shown to have effect in mouse or rat models in ADPKD, but human and rodents are very different, and many studies that may be effective in these animals may not actually work in human due to a number of reasons.
Understood. Thank you. We'll speak about this in a presentation later this afternoon, but did you want to add your input to the safety and effect of a keto diet on polycystic kidney disease? I know that's a big question to ask this late in the presentation.
Yeah, so you have the expert here who is going to talk to you a bit more. But from my own perspective, I think that I think it is important to have careful monitoring, like by a physician, if you decided to do that. There's a lot of unknown, like much of the literature is generated by animal model. The human study in terms of control trial, I think are emerging, and there will be some. I think it is quite likely a very promising approach, if anything, to reduce weight and improve the metabolism. Whether it will slow PKD is a more challenging question to test in the clinical setting. But hopefully, I do hope that researcher will pick it up and maybe through collaborative effort to really test this more vigorously.
Understood. And as you mentioned, we will have Dr. Thomas Wimes speaking on this in long form later this afternoon, but thank you for your input. We have time for 2 more questions that are in the question box, and then we'll be moving on to Dr. Nev's presentation. Good morning from Malaysia. I'm a 53-year-old female diagnosed with PKD 30 years ago. I'm now at stage 5 with GFR being 12. Can I still take tolvaptan at my stage? Do I have to control my fluid intake?
I think at this stage, I think the utility of tolvaptan is very minimal. And in general, after GFR falls below 15, we stop the tolvaptan and generally prepare the patient for dialysis or for transplantation. This is our practice.
Okay, we have 2 more, but I'll answer one leading into the last one. When someone with a kidney transplant or when someone receives a kidney transplant, are they healed from PKD? So of course, post-transplant, you're still living with polycystic kidney disease. It still has an impact on the other organs in your body as a whole. Is there anything that you would want to add to that, Dr. Pei?
Not really. I think that the complication outside the kidney are less predictable. For example, aneurysm or the GI involvement or the cardiac involvement. Most of the time they are really mild, but sometimes it could be serious, and it's very individual and depending on whether it happened in a specific patient. But I think being aware that such complication can occur, it's important, and to have the doctor monitor and watch out for them, I think would be prudent.
Very good insight, thank you. Last question, can a transplanted kidney in a PKD patient develop cysts?
Yes, cysts are very non-specific. It can happen in general population, but just because it develops cysts in a transplant kidney doesn't mean that it's polycystic kidney disease. And by and large, these few cysts that may develop in a transplant kidney had very little consequence on the kidney function.
Okay, that will conclude our time, Dr. Pei. Thank you so much. And I know I speak on behalf of all the attendees as well. Thank you so much for your informative presentation, for the decades of work that you have put forth to the PKD community and the research world. We're glad that you were part of our very first virtual PKD summit. And I hope you enjoy the rest of your time in Vancouver.
Okay, thank you, my pleasure.
All the best, Dr. Pei. Bye-bye.